Ideally, what would happen is a woman would come to a doctor and say, hey, I want to get pregnant. What do I need to do to make that happen and be the healthiest I can for baby and myself? It doesn't always happen that way, as pregnancies can be unplanned, and not everyone has that amount of access to an obstetrician. But if mom is pregnant or thinks she is, the first time you should evaluate her, the first trimester evaluation happens at about week 10. In that session, your goal is to do screening. And a lot of this stuff is automated by order forms. So committing to memory exactly what you need to do isn't really worth it, but focusing on the things that you need to act on that change the risk of the pregnancy makes a lot of sense. But we'd like there to be some preconception counseling. That is, mom comes in and says, I'm not pregnant yet, but I'd like to be. Planned pregnancies, barring catastrophic genetic disease or trauma or advanced maternal age, generally do better than unplanned ones. So trying to plan makes sense. In that preconception period, what you want to do as a major focus is focus on safety. And safety is going to be the safety of the pregnancy in the way of genetic history or genetic risk, as well as maternal age. Advanced maternal age makes aneuploidy and loss of fetus increased risk. If they have one of those things, they should be sent to somebody who handles high-risk pregnancies. But also you want to screen for domestic violence and abuse, both physical and emotional. Domestic violence and abuse significantly increases. Pregnant women, children, and the elderly are at highest risk and are special populations for domestic violence. And so making sure she's ready to have a kid and has the social support to do so is crucial to a successful pregnancy. Some usual routine stuff, like prenatal vitamins with a focus on folate, should be emphasized. Folic acid prevents neural tube defects. And this is actually really important to know. The fetus is most vulnerable in the earliest stages of development. And so having mom ready for the pregnancy, planning it, means that you can avoid teratogens or toxins or things that are unhealthy for the baby at its most crucial time. One of those are going to be vaccines. Mom should be up to date with flu, Hep B, and the MMRV, measles, mumps, rubella, and varicella. The most important one to focus on here is the MMRV. Because it is live attenuated, you cannot give it to mom after she's pregnant. You'll induce a viremia and cause the birth defects. We talk more about this in the prenatal infections lesson. The flu shot should be given intramuscularly and can be given while you're pregnant. The intranasal form is a live attenuated virus. And Hep B should be achieved vaccine status prior to becoming pregnant, but can be given during pregnancy. And then you're going to focus on lifestyle. And there's a lot of stuff out there about what moms should do in order to have the best pregnancy. We as a medical community have definitely sided with smoking and alcohol cessation. And if she's doing anything illicit, she should stop. It doesn't matter what drug she's using, even if it's a benzo to help go to sleep, or other medications that might be teratogenic, you need to get her off everything. And things that are going to help mom emotionally and intellectually are going to be things like sleep, stress, sex, and work. She is going to have to work for a while, but she should plan maternity leave. It is safe to have sexual intercourse with her partner despite being pregnant. And getting on a sleep cycle and reducing stress is going to be better. It is okay for mom to change her plans and not necessarily work full-time while she's pregnant. She may not need to go on maternity leave for 9 months, but this is up to her, and you should discuss what her options are and what she wants to do. And lastly is optimization of disease. The ones you want to focus most on are going to be diabetes, hypertension, and hypothyroid. The reason for this is that the medications you normally use to treat these diseases are going to be teratogenic, especially hypertension meds. So the goal is to achieve adequate control and get them off the medications that they're usually on in order to prepare them to manage their disease during pregnancy, specifically insulins for diabetes, alpha-methyl-dopa, labetalol, and hydralazine for hypertension. More on that in the medical disease lesson. The problem is that these are often teratogenic with the medications they treat, and hypothyroidism, because of the physiologic changes of pregnancy with increased proteins, you may need to increase the dose. All right, that's preconception. That's what you like to do before she comes in, before she gets pregnant. But at that first trimester evaluation, you want to engage the person, the pregnancy itself, do some confirmatory testing, and then the screening labs that are going to help you figure out what mom's risk for this pregnancy is. The first question to ask mom is the pregnancy desired? Don't assume everyone will be happy because they are pregnant. And you should use her belief system, not yours. So you should offer her things like termination, which is definitely okay at week 10, as well as parenting and adoption. So you should work with her to find out if it's desired or not and figure out what she wants to do with this pregnancy. The next thing you want to do is assess barriers to care. Especially in the indigent populations, a patient may not be able to get to you as often as you'd like. The bus system doesn't work. They can only come in once every 4 weeks because that's when they've got time. They work the night shift. Whatever the case may be, we need to make sure that they have access to healthcare. And you may not be able to address this when they're in their preconception phase because becoming pregnant gets you insurance. You also want to care about her baselines, which are going to be primarily her vital signs and weight. You're going to track weight gain, and she should not be hypertensive. And of course, again, especially if you hadn't had a preconception meeting, you want to assess for abuse and safety. When we talk about the pregnancy, you're going to do a full history and physical bimanual exam, of course. But the things you want to focus on are going to be particularly the obstetrical history. And this is very useful. When you take a test, especially the USMLE, you don't know a question is an obstetrics question. But if they give you Gravid 2 Para 1 in the STEM, you know it's OB. What do I mean by that? There are two systems that are in use. The GPA system, which is gravid uterus, parauterus, and abortions. Limited because a gravid uterus counts once for each event pregnancy. And that means if she's pregnant once but has 5 fetuses, it counts as gravid 1. Same thing with para, it's the number of delivery events, that is 5 gestations count as 1 delivery. So you don't know how many children she's actually had, and abortions is listed for loss of any reason. The other method is TPAL, which is term pregnancies, preterm pregnancies, abortions, and living children. The idea here is that you count the number of individual fetuses, individual humans that were brought to term, that were delivered preterm, that were aborted for whatever reason, spontaneous or induced, and how many are living. And some people like to throw on the G to the beginning of TPAL to cover the gravid portion, break up para into term and preterm, and include abortions and living. Which method you use is likely to be dependent on your attending, resident, or whatever happens to be going on at your institution. When you're doing the history, in addition to obstetrics, you want to make sure that you get a good grasp of the social history, the medical history, the surgical history, the medications she's taking, her allergies, and family history, to try to decide what are her risk factors. Bimanual exam, and then we'll get to the labs. Just because she thinks she's pregnant doesn't mean she is. So the first thing you need to do is screen for her pregnancy. That first test is a urine pregnancy test. If that's positive, the best test is an ultrasound. What it does is confirms intrauterine pregnancy as opposed to ectopic, determines the gestational age, and assesses for multiple gestations. If the pregnancy is too young, before 10 weeks, it may not be big enough to be seen by an ultrasound. In that situation, you might use the serum beta-HCG. Most of the time, HCG in the blood is not necessary. You do that when you're considering pathologic states, either an ectopic pregnancy, choriocarcinoma, mole, hyperemesis gravidarum. It's a UPT confirmed with ultrasound. And then comes the list of tests you're going to screen for. And we break it down into blood, urine, and if needed, cytology. What you're doing is trying to establish baselines, determine risk, and assess for STIs. STIs which can be transmitted to baby. So the first thing you want to do is all about anemia. You're going to type and match mom. So if she needs blood later, we know what she needs. But more importantly, you're going to assess her rhesus antigen status, whether she's positive or negative. We talk more about this in medical disease and again in alloimmunization. If mom is antigen negative, she can prime her immune system to attack baby and cause fetal anemia on a subsequent pregnancy. More on that in subsequent lessons. You also want to know mom's baseline hemoglobin. And I'll say this a bunch in this series. Some people are hemoglobin people, some people are hematocrit people. That is the same thing. Hemoglobin times 3 is the hematocrit. Some people like to use the crit, some people like to use the hemoglobin. But you want to establish baselines because she is going to reduce her hemoglobin because of dilution. And you also want to assess for underlying anemias that are already present. Iron deficiency, thalassemias. Some STIs we need to investigate for are going to be HIV and a confirmation test if it's positive, or hepatitis B antigen status, an RPR for syphilis, and treat it with penicillins regardless of penicillin allergy if she is positive, and then determine her titer levels specifically for those ones that she's unable to get when pregnant, that is varicella and rubella. If she is vaccinated appropriately pre-conception, you should still get the titers to make sure she's immune. If she's not immune, she needs to be removed from potential exposures. In the urine, we do a screening urinalysis and urine culture. We do treat asymptomatic bacteriuria, as we'll discuss in the medical disease topic. But the urine it also helps us establish baselines for proteinuria, which can be used to assess whether she's becoming eclamptic, and it screens for gonorrhea and chlamydia. If you find one, treat the other. Cytology is all about the pap, and if she needs a pap, she gets one. Doing a pap doesn't harm baby. Some other stuff that you might do at this first evaluation that we're not going to talk about here are genetic screens. We have panels in the United States. You do not have to remember what's on it. The two that are going to come up the most are going to be cystic fibrosis, Caucasians, and sickle cell disease, African Americans. Screening is not offered to everyone all the time. Not all forms of screening are going to be utilized. We talk more about this in the genetic disease lesson that follows. But then, after seeing her and having all this information, you need to know when to bring her back. How do you do follow-up? And follow-up increases in frequency the later in pregnancy she is. You're going to see her Q4 weeks for the first 2 trimesters up to week 28. Then you'll see her every 2 weeks after that until term, and then every week after that until delivery. The idea being, as you get closer to delivery, you want to make sure you're having more frequent assessments because the pregnancy impacts mom more, and delivery is easily done, but you can't do it if baby dies. Lots we talked about. I want you to focus on the highlights. Preconception is about safety, vitamins, and vaccines. Get mom to stop doing the bad stuff and get on the medications that are necessary to treat her chronic diseases that are safe for pregnancy. When she comes in for the first time at 10 weeks, you want to find out about her Is the pregnancy desired? What are the barriers to care? Is she safe? Establish baselines of hemoglobin, vitals, and weights. Know how to describe the pregnancy, diagnose the pregnancy with a UPT followed by an ultrasound, and then do the usual screening labs with a major emphasis on rhesus antigen status, mom's baseline hemoglobin, urine cultures and urinalysis for bacteriuria, and then STI screening and potential treatment versus vaccination based on what you find. That is first trimester evaluation.